welcome to This Explainer. Today, we're diving straight into one of the absolute highest stakes, most deeply complex challenges in all of medicine. We're talking about the clinical detective work behind diagnosing schizophrenia. This isn't just about checking off a list of symptoms from some dusty textbook. It's really about untangling the incredibly intricate realities of the human mind.
So, to kick things off, I want you to just ask yourself a quick question. If you were to walk into an emergency room right now, how easy do you think it would be to fake a severe psychiatric disorder? I mean, imagine if saying just one, very specific word could get you committed to a psychiatric hospital. Sounds totally impossible in modern medicine, right? No way that happens.
Well, actually, let's look back at a total watershed moment in psychiatric history. It's the famous 1973 Rosenhan study. Here's what happened. 8 completely healthy people walked into psychiatric hospitals complaining of literally just one symptom. They said they heard the words empty, hollow, thud. That's it. And guess what? They were all admitted, and every single one of them was diagnosed with schizophrenia. Once they were inside, they acted completely normally, but that diagnosis stuck to them like glue. It's wild, but it perfectly illustrates the extreme dangers of relying on single, isolated symptoms, and exactly why we need rigorous, ironclad diagnostic criteria. It's an absolute necessity.
Which brings us to our first major step. Section 1, the puzzle pieces, defining the symptoms.
All right, so to solve this puzzle, we have to gather the right pieces, and the symptoms of schizophrenia are classically split into 2 major camps. On the left, we've got positive symptoms. Now, these aren't positive like a good thing. It just means the presence of abnormal experiences being added to the patient's reality. We're talking about florid delusions and auditory hallucinations. Then on the right side, we have negative symptoms. These represent a really devastating loss of normal functioning and emotional expressivity. And while the positive symptoms definitely get more attention in movies, it's actually the negative symptoms that quietly but drastically strip away a person's ability to just navigate their daily life. To make sense of these debilitating negative symptoms, psychiatrists often categorize them as the 4 A's. First up is allosia, which is basically a decrease in spontaneous speech. Then there's avolition, a profound drop in overall motivation. Next is affective flattening, where the face and voice just completely lack normal emotional expression. And finally, anhedonia, which is the really tragic inability to feel pleasure. Grouping them like this, into these 4 A's, gives us a highly structured but also incredibly empathetic understanding of exactly what this patient is losing as the illness progresses.
Now, swinging back to the positive symptoms, there's a truly fascinating concept called the autothoctonous, or primary, delusion. This is a delusion that appears totally suddenly, literally out of nowhere, and with absolute conviction. There's no train of thought, no prior mental event that leads up to it. For example, a patient might just suddenly and completely become convinced that they are changing sex for absolutely no logical reason whatsoever. It's a prime example of how abruptly and completely a patient's entire reality can just shift, and because of that, it carries a massive amount of weight in the diagnostic process.
And there's another crucial concept historically used to solve this puzzle. They're called Schneiderian first-rank symptoms. These are very, very specific abnormal experiences. We're talking about things like hearing voices that are giving a running commentary on your actions, or the downright terrifying sensation that your own internal thoughts are being broadcast out loud for everyone else to hear. For a long time, psychiatrists believed that if you undeniably had these, they held a special, almost definitive diagnostic value pointing straight to schizophrenia. But, as any good detective knows, the evidence rarely stays static. So let's look at Section 2, the complication. Evolving subtypes and phases.
You see, schizophrenia isn't just some frozen snapshot in time. It actually unfolds in distinct phases. The acute phase often looks like a sudden, intense crisis. It's completely dominated by those florid positive symptoms we talked about: intense paranoia, major behavioral disorganization. But if we track the illness over a longer period, we often see a transition into the chronic phase. And here, the positive symptoms might actually quiet down. But those debilitating negative symptoms, the 4 A's, they really take over, bringing along significant cognitive deficits.
Because these presentations can vary so wildly, clinicians historically tried to categorize the disorder into subtypes. You've probably heard of paranoid schizophrenia, right? That's the most common one, marked by persecutory delusions. But there was also hebephrenic or disorganized schizophrenia, which features super unpredictable behavior and rambling speech. And then take a look at the catatonic subtype. That one is characterized by extreme motor symptoms, like a complete stupor or even violent excitement. But here's the wild part. Catatonic schizophrenia has mysteriously become exceedingly rare in industrialized countries today. Nobody is entirely sure why. Maybe it's better treatments, changes in the illness itself, or maybe we were just misdiagnosing organic syndromes in the past. It is a genuine medical mystery.
So, how on earth do clinicians make sense of all these shifting phases and historical subtypes today? Well, they turn to the modern rulebooks. Section 3, ICD-10 versus DSM-5.
When we put the two massive pillars of psychiatric classification side by side, that's the American DSM-5 and the international ICD-10, we actually see some incredible discrepancies. For instance, the DSM-5 completely removed all those historical subtypes we literally just talked about, basically deciding they were unreliable, but the ICD-10, they kept them. The DSM-5 also entirely removed Schneiderian first-rank symptoms from its core diagnostic criteria, whereas the ICD-10 still relies on them heavily.
But the absolute biggest difference between the two? It comes down to the number 6. Under the DSM-5 rules, a clinician has to observe continuous signs of disturbance for a strict minimum of 6 whole months before they can officially diagnose schizophrenia. It's essentially a built-in waiting period, entirely designed to prevent doctors from rushing into a misdiagnosis of what might just be a temporary psychosis.
Contrast that 6-month rule with the number 1. The ICD-10 requires only a single month of symptoms, provided the patient is exhibiting very clear, specific signs, like those first-rank symptoms we mentioned earlier. It represents a huge, fundamental, philosophical difference in exactly how the world's leading medical authorities go about piecing this clinical puzzle together.
Which brings us to the most critical part of our detective work. Section 4, ruling out lookalikes, the differential diagnosis.
Listen, before any doctor can confidently stand there and say, this is schizophrenia, they have to systematically prove that it isn't something else entirely. Step 1, they absolutely must rule out substance-induced psychoses or severe medication side effects. That's a must. Step 2, they have to scan for organic physical brain diseases. For example, things like temporal lobe epilepsy or acute delirium can present exactly like acute schizophrenia. In fact, one study found that nearly 4% of first-episode schizophrenia cases actually turned out to have a physical organic cause. And step 3 is differentiating it all from severe mood disorders.
So the really crucial point here is navigating this super tricky boundary where psychosis and mood disorders overlap. It's a gray area. If the psychotic symptoms are the primary issue, then it's schizophrenia. But what if you have definite schizophrenic symptoms and definite, intense mood symptoms, like severe mania or a crushing depression, and they are equally prominent and happening at the exact same time? In that case, the clinician has to use a completely distinct diagnosis, schizoaffective disorder.
And, it is also incredibly vital to reassure patients and their families that a temporary break from reality can happen without it turning into a lifelong chronic condition. If psychotic symptoms last for at least 1 day, but then fully resolve in less than a month with a complete return to normal functioning, it's classified as a brief psychotic disorder. The puzzle pieces might look similar at first glance, but the timeline dictates a completely different outcome for the patient.
Looking back at everything we've covered today, I really want to highlight this powerful quote from the source text. The term now refers to a syndrome that can be diagnosed reliably, which is essential for rational clinical practice. I love that. Because despite past historical missteps, like that crazy Rosenhan study where the words empty, hollow thud got totally healthy people committed, we now have incredibly meticulous, highly reliable systems for ruling out lookalikes and pinpointing the exact nature of this illness.
But of course, the science is never really finished. As we increasingly map the human genome, as we identify complex epigenetic markers, and as we use advanced living brain imaging like PET and fMRI scans, the underlying biology of schizophrenia is finally starting to come into the light. Which leaves us with this final provocative thought. As we unlock the epigenetic and neurobiological secrets of the brain, how will our diagnostic rulebooks evolve next? Are symptom checklists eventually going to be replaced entirely by genetic and biological profiles? It's a truly thrilling frontier. Thank you so much for joining me on this explainer, and remember to always keep questioning what we know.